Hi, everyone. I'm Dr. Marcus Greatheart. I use he, him pronouns. I am a family physician and addictions provider currently in Campbell River, the unceded territory of the Lakwatak, Weewakai, and Weewakam people. I'm also a social worker by training and want to identify my social locations as a cis queer white physician who's been working in queer trans health for more than 30 years. And really excited to be with you all here today. As Trevor mentioned, we have a lot of material to cover in the lecture. And so I'm going to dive right in. And Trevor, if there's anything that I'm missing, what have you, you'll speak up and let me know. I'm going to try and balance the amount of content with some with a bit of speed in order to sort of get through the information so we can dive into this great case that Dr. Sussman's brought. So in terms of learning objectives today, we're going to be describing some of the patterns of use, substance use among two-spirited lesbian, gay, bisexual, trans, queer, and questioning, intersex, asexual, and other sexual and gender diverse people. The 2S LGBTQQIA plus people. We want to identify some of the barriers to accessing substance use disordered care for these communities, and we'll talk about the 8 guiding principles of affirmed care for these communities. So this acronym seems to be expanding. In fact, what I'll tell you is that when I first started doing care with queer communities, this was back in 1990, when I first moved to Vancouver. I started volunteering at what was then called the Gay and Lesbian Center on Butte Street at Butte and Davie up on the 2nd floor, which has had shifted names. So at that point, Gay and Lesbian Center was sort of the limit of the moniker. It has since expanded. It's important to acknowledge that language surrounding gender and sexual identities is ever evolving. The complexity of this means that these terms can mean slightly different things to different people at different times. Therefore, it's important for care providers to reflect on the language and the definitions used by each individual person accessing care. Let's go through it a bit. Two-spirit or 2S reflects the complex Indigenous understandings of gender roles, spirituality, and the long history of sexual and gender diversity in some Indigenous cultures. Lesbian describes a woman-identified person who is emotionally and sexually attracted to people of their own gender. Gay describes a person who is emotionally and sexually attracted to people of their own gender, and it can be used regardless of their gender identity, but is more commonly used to describe men. Bisexual describes a person who is sexually and or romantically attracted to 2 or more genders. There's that gender binary, again, though not necessarily simultaneously in the same way or to the same degree. Now, transgender is an umbrella term for people whose gender identity and or their expression is different from cultural expectations based on the sex that they were assigned at birth. Being trans does not imply any specific sexual orientation, and trans people may identify as straight, gay, lesbian, bisexual, any among the acronym. Queer and questioning. Queer is a term that can be used by a community to encompass a broad spectrum of identities related to sex, gender, or attraction. It can also be used by an individual, as I do, to reflect the interrelatedness of these aspects of their identity. Questioning is a term that describes people who are uncertain about their gender or sexual identity, either in a transitory or maybe even a permanent state. Intersex, used for a variety of conditions in which a person is born with reproductive or sexual anatomy that does not seem to fit in the typical definitions of male or female. Asexual refers to individuals who do not experience sexual attraction towards others. It's important to distinguish sexual attraction from romantic attraction, though, as some asexual individuals might identify as aromantic, meaning not experiencing romance. However, these are 2 separate identities. Asexuality exists on a spectrum, with some asexual people experiencing varying levels of desire for different types of physical intimacy, which may fluctuate over time or by the person. Finally, the plus sign represents any additional sexual or gender diverse people not captured within the acronym, trying to be as inclusive as possible. Next slide. So the ideas of sex, gender, sexuality can often be conflated and confusing, and so want to offer a little bit of clarity. So sex is the biological category assigned to people based on reproductive, anatomical, hormonal, and genetic characteristics. These categories include male, female, and intersex. The characteristics are diverse, and some of these can change over the course of a person's life. When in my training, I was on my obstetrics and maternity rotations. It's the identification frequently that the health provider makes at the time of the birth that says this baby is a blank. Gender, on the other hand, refers to the socially constructed concepts specific to certain cultures, such as femininity and masculinity. Within this, gender can be further described by gender assignment, identity, roles, and expression, where gender assignment is the gender a person is assigned at birth. Gender identity is what a person defines as their own gender. So it's how they see themselves. Sexuality refers to the sexual or romantic feelings they have towards others. For some people, this involves the absence of sexual feelings or romantic feelings for anyone. As many people experience attraction to different people and different genders throughout their life, sexual orientation is best described by experiences of attraction rather than their behaviors. So who a person feels attracted to may not be the person that they are in a sexual relationship with. Next slide, please. So what do we know about the patterns of substance use among this complex and beautiful group of people within the 2S LGBTQQIA+ community? So research, of course, is lacking. Many of the existing studies that we mentioned here were conducted in the US. Some of them are over 14 years old. So there are many limits to the data and research that we have. The amazing writing team at the BCCSU has done their darndest to try and pull together the best information that we have available. There are some issues with some of the methodology that were noted. There are some longitudinal international studies in progress right now that we're hoping will be able to provide better data around substance use. So understanding those limitations, here's a bit of what we know. So patterns of substance use within these communities can differ from individuals who don't identify as part of these communities, obviously. And even within these communities, patterns might not be applicable to all members within those groups. So here we're comparing individuals to people who are both cisgender and heterosexual. So in that comparison, lesbians and bisexual women show higher odds of past-year alcohol use disorder. Gay men, bisexual men, and men who have sex with men don't identify as gay or bisexual have greater rates of methamphetamine use. Gay men report lower heroin use. Bisexual people demonstrate higher rates of cannabis use disorder and medical cannabis use. Trans people demonstrate a higher likelihood of using cocaine and amphetamines and a higher prevalence of high-risk drinking. And non-binary people demonstrate increased risks of high-risk drinking. Next slide, please. So what's this relationship between gender and sexual identity with substance use? It's really unclear. Increased rates of substance use may reflect the use of substances to cope with discrimination and stigma that are often directed at members of these communities. The minority stress model is frequently raised. It asserts that chronic exposure to factors such as violence, racism, microaggressions, stigma, and discrimination result in internalized distress, which can lead to mental and physical health challenges. This can lead members of these communities to feel reluctant to share their gender or sexual identities in healthcare settings. Also, 2S LGBTQQIA positive plus folks also face targeted advertising and sales tactics that increases their exposure to alcohol and tobacco marketing. Next slide, please. Within Indigenous cultures, Two-Spirit people have historically been respected and are important community members, often holding key roles such as knowledge keepers and chiefs. However, colonial practices have essentially erased the established roles and cultural significance of Two-Spirit people and replaced them with Western concepts and expectations of the binary gender and heteronormativity through strict distinctions between boys and girls in residential schools. Two-Spirit people face higher rates of depression and anxiety, where substance use becomes a coping mechanism due to the compounded experiences of homophobia and transphobia, as well as heteronormativity, intergenerational trauma, and targeted violence perpetuated by ongoing colonial processes. While access to culturally safe healthcare remains limited, Two-Spirit people demonstrate ongoing resilience amid intersecting challenges of racism, homophobia, and colonial oppression, drawing strength from their cultural heritage. Acknowledging and learning from the strength and knowledge of Two-Spirit people and their historical role within Indigenous cultures can inform programs that support Two-Spirit people in feeling safe to access healthcare spaces that seek to promote holistic wellness. We'd like to take a moment just to take a look at this artwork by Satsi on the next slide. Interestingly, the artist's note in their about their artwork says about this piece: in the center is a carved mask wearing a nose ring and a stretched labret, symbolizing the breaking of gender norms and gender assignment that Two-Spirited people represent. On either side of the mask are ravens, said to have been shapeshifters among the Northwest coast. The gay and transgender flags are also represented, and I chose orange as a background color to remember the LGBTQA2S+ Native youth who have been through residential schools. I chose to represent the mask as an older person with graying hair to remind people that by choosing love and acceptance for all people, we will be gifted to see these LGBTQA2S+ people become present and future cherished elders. The main message of this design is that we have always been and will always continue to exist. By decolonizing our viewpoint of the LGBTQA2S+, we will remember the love and acceptance and even celebration of the LGBTQA2S+ community. Next slide, please. Continuing on the theme of barriers to accessing care, erasure is such an important topic. People seeking care can face covert and overt transphobia, biphobia, and homophobia, which are barriers to substance use care. Informational erasure includes the lack of knowledge regarding these communities and the assumption that this knowledge is not necessary. This can lead to use of language that assumes cisgender heterosexuality among its clients. It can also directly impact the care a person receives. For example, referring an individual to an inpatient or bed-based service that does not align with the client's gender. People who are accessing care may not disclose relevant details. They might feel unsafe and might not return for follow-up care. This in turn can reduce providers' competence in providing care for 2S LGBTQIA people. Next slide, please. In addition to informational erasure, institutional erasure also presents as a barrier to accessing care. Institutional erasure talks about the lack of policies and practices that accommodate 2S LGBTQQIA plus people, including a lack of knowledge that such policies are even necessary. This could indicate to people seeking care that they are not acknowledged and not accepted. For example, a lack of gender-inclusive washrooms could make providing a urine sample feel unsafe, which could ultimately be a barrier to continuing to receive pharmacotherapy. Similar to informational erasure, institutional erasure can also reduce providers' competence in providing care for these communities. So, what are the principles of affirmative care? It's on the next slide, please. Here's an overview. There are 8 guiding principles to inform care for 2S LGBTQQIA plus people. Next slide. There we go. Thank you. Preparation, person-centeredness. We want to facilitate safety, exercise non-judgment, respect, and be welcoming, foster dignity and respect, recognize that social support networks can be diverse, provide evidence-informed care, practice reflexivity and reflection. All right, let's talk a bit more about these. A lack of person-centered care is one of the barriers that 2S LGBTQIA plus people experience when seeking care. Some examples of this can look like referring a trans patient to a detox bed or a recovery facility that doesn't align with their gender identity, or providing substance use care to gay, bisexual, or men who have sex with men who who engage in party and play activities, also known as chemsex, without talking about the sexualized component of drug use. Further, 2S LGBTQQIA plus populations require environments that are culturally safe, supportive, affirming, destigmatizing, non-judgmental, and where they're treated with dignity and respect. A lack of person-centered care can result in people not engaging or actively disengaging before their care needs are met. Next slide. We don't want to burden members of this community by asking them to educate us on the spot when they are seeking care. For example, asking a person accessing care broad questions, such as what does it mean to be trans or two-spirit, or asking them to call the provider out if they say something incorrect. We also want to be able to address 2S LGBTQIA plus individuals and their needs in ways that affirm their gender, sexuality, or sexual identity in non-judgmental ways. For example, as the provider, share your pronouns with all people accessing care. Offer an opportunity for the person to share their pronouns and ensure you use the correct pronouns in conversation. And here's a tip. Consider how clinicians can be reminded of a person's name and pronoun if they differ from their medical records before each visit. Have a system to flag a person's name and pronouns for the provider to help eliminate this error. We want to take into account people's diverse identities and experiences. 2S LGBTQIA plus people are diverse in race, class, ability, cultural and spiritual beliefs, and personal values. We want to consider how intersectionality can impact a person's experiences and interactions with the healthcare system. For example, someone can be a member of the 2S LGBTQIA community, as well as a marginalized and excluded race. All aspects of a person's identity can impact their access to and experience with healthcare and the social determinants of health. For example, 2S LGBTQIA plus person of color's experience and access will be different from a member of that community who identifies as white. And here's a tip. This is a highly heterogeneous community. Clinically, it is best not to make assumptions, to ask informed questions, demonstrate your cultural competency and interest in learning and understanding a person's individual health needs with respect to substance use. Next slide. We want to create a culturally safe and supportive space for 2S LGBTQQIA plus people. Some examples of this can look like using non-gendered or gender-inclusive language, or providing specific resources and referrals. We want to provide them with the opportunity to share their sexual and gender identities as well as their pronouns without requiring them to do so. We should not share a person's sexual or gender identity with other people, including members of the staff within the organization, without the individual's specific permission. And here's another tip. Gender and sexual identity should be considered when providing a referral. Ask the client receiving care if they're comfortable with their sexual and gender identities being disclosed in their referral, and explain to them the purpose of such a disclosure. Next slide. We want to be non-judgmental, respectful, and welcoming by not making assumptions about a person's situation. Using inclusive, non-confrontational, destigmatizing, and anti-racist language when communicating both verbally and in written communications. We want to tailor clinical care to the individual circumstances, risks, and preferences, especially where biological sex may impact their treatment. When discussing screening and procedures, for example, especially ones that are commonly associated with one gender, we want to consider referring to that person to body parts or organs rather than their gender. So, for example, instead of saying women should receive cervical cancer screening every 3 years, you might say people with a cervix should receive cancer screening every 3 years. Next slide. We want to try and empower 2S LGBTQQIA plus people to make informed and collaborative decisions, including tailored treatment plans that align with their ideal substance use outcomes, whatever those might be, and provide a variety of treatment options so that people can make informed decisions. Sex, sexual orientation, gender identity, and gender expression are all protected classes in BC under the Human Rights Code, and it's important information for us and our clients to know. We want to practice cultural safety and humility. And here's a tip. Consider how trans and gender diverse people's dignity and needs can be respected when providing urine samples, for example. Next slide. We want to recognize that social support networks can be diverse and that people's families may include chosen families, families of origin, entire communities or nations, significant others, and other folks from the 2S LGBTQIA plus communities. The use of non-assumptive and inclusive language is recommended when asking about families and support systems. For example, one could ask, who do you consider family? Or who are the supportive people and pets in your life? Next slide. As with all people, substance use care should be evidence-based and informed by knowledge and research on the specific needs and barriers the 2S LGBTQQIA plus communities experience. For Indigenous people within these communities, evidence-informed care may integrate experiential insights that are enriched by cultural practices. Acknowledging and offering Indigenous-specific options that are culturally safe fosters a respectful and trusting care partnership. Use a harm reduction approach informed by the knowledge from and experience of these communities. And as an example, we want to specify, for example, that HIV tests are being offered to all people, as it's been found to reduce or eliminate. So let me say that again. So we recommend specifying that HIV testing is offered to all people, as this strategy has been found to reduce or eliminate concerns experienced by young gay men about being specifically targeted around HIV screening. Next slide. Reflexivity is the ongoing practice of examining our own values, beliefs, and life experiences to identify their impacts on the care that we provide. To practice reflexivity, care providers can, for example, examine how their social locations, identity, experience, and biases inform how they react or treat people who are accessing care. Practicing reflection enables self-directed learning and improvement of the care that we provide. Reflection and learning should include considering beliefs and values about 2S LGBTQQIA plus people and communities, as well as the ongoing legacy of colonization in Canada, which impacts queer, trans, and two-spirited Indigenous people. We want to recognize the power differential between care providers and the clients who are accessing care. We want to acknowledge that allyship is not a self-appointed identity, and that requires an ongoing commitment to actively work in and with the community. We want to follow the lead and the language of 2S LGBTQQIA plus people. Another clinical tip, consider the ways that your experiences are similar to or different from people receiving care and how this might impact their care. For example, people with same gender partners might have different definitions of sex than heterosexual people do. To summarize, some populations within the 2S LGBTQQIA plus community are more likely to experience substance use related harms and higher than average rates of substance use than people who are not part of these communities. It's crucial not to generalize trends to specific individuals or populations within the 2S LGBTQQIA plus community. Instead, it's important to be mindful of potential differences to prevent making generalized assumptions. Erasure and a lack of person-centered care are enormous barriers to care and contribute to negative health outcomes and health inequalities. And we spoke today about 8 main guiding principles for 2S LGBTQIA plus community. These are preparation, maintaining a person-centered approach, practicing non-judgment, upholding dignity and respect, recognizing the diverse social supports that can exist, providing evidence-informed care, and practicing reflexivity and reflection. Thank you so much for this opportunity to speak with you today. We've provided some resources that we'll make available to you as well from within British Columbia. And I'll hand it back over to you, Trevor.